Good afternoon, and welcome to today's webinar, Strategies for Reducing Analytical Interferences in the Clinical Chemistry Laboratory. I am Carrie Denham, and I'll be your moderator for today's event. We are delighted to bring you this webinar presented by AACC and supported by a generous grant from Ortho Clinical Diagnostics. This program is accredited for Accent Continuing Education credit. I'd like to point out that our webinar session will conclude with a Q&A session. You can submit your questions at any time during the webinar through the Q&A dialog box in the bottom right-hand corner of your screen. However, questions will not be answered until the Q&A portion of our program. To ensure your Q&A dialog box is open, please make sure that the Q&A box icon at the bottom of your computer screen is blue. If the icon is black, click on it and your Q&A panel will become visible. So let's get started. As a global leader in vitro diagnostics, Ortho Clinical Diagnostics is proud to sponsor this educational program to provide laboratorians with educational information on managing potential interferences in the lab. It's part of our commitment to the customers we serve. Across hospitals, hospital networks, blood banks, and labs in more than 125 countries and territories, Ortho's high-quality products and services enable healthcare professionals to make better informed treatment decisions. For the immunohematology community, Ortho's blood typing products help ensure every patient receives blood that is safe, the right type, and the right unit. Ortho brings sophisticated testing technologies, automation, information management, and interpretation tools to clinical laboratories across the world to help them run efficiently and effectively and improve patient care. Ortho's purpose is to improve and save lives with diagnostics, and it does that by reimagining what's possible. This is what has defined Ortho for more than 75 years, and it's what drives Ortho forward. Again, thank you for joining us in today's Ortho Clinical Diagnostics webinar, Strategies for Reducing Analytical Interferences in the Clinical Chemistry Laboratory. Our speaker, Dr. David Grenache, is the Chief Scientific Officer and Medical Director of the Chemistry, Immunology, and Esoteric Chemistry Labs at Tricor Reference Laboratory in Albuquerque, New Mexico. He is also a clinical professor of pathology at the University of New Mexico. He earned his PhD in biomedical sciences from Rochester Polytechnic University in Rochester, Massachusetts, and completed postdoctoral training in clinical chemistry at Washington University School of Medicine in St. Louis, Missouri. His clinical interests include the use of laboratory data to gain insight into population health. He also maintains a blog called The Pregnancy Lab that is focused on laboratory tests used to manage the pregnant patient. Dr. Grenache, you may now begin your presentation.
Great. Thank you so much for the opportunity to speak today, and thank you to Ortho for supporting the webinar. Okay. There we go. So here are my disclosures. And before I get started, I want to tell you a little bit about Tricor Reference Labs, where I work. Tricor was formed 20 years ago as a not-for-profit company in partnership with the state's two largest healthcare providers, those being the University of New Mexico Health Sciences Center and Presbyterian Health Services. We are the largest clinical lab in the state, and we operate as a hub-and-spoke model. The hub is the reference lab located here in Albuquerque, and the spokes are the 17 hospital labs, 12 branch labs, and 28 patient care centers that provide lab tests appropriate for their populations, but they send all the remaining work here to the reference lab. As a system, we perform more than 14 million tests annually, so we see our fair share of sample interference issues. And here are my objectives for today's webinar. So the frequency of errors in the laboratory has been documented in many studies. Pre-analytical sources of error are the most commonly encountered and include things like inappropriate test utilization, errors entering the test orders, identifying patients properly, collecting and labeling samples, just to name a few of them. Errors that occur during the analytical phase of testing are generally the least common sources of lab error and include things like equipment malfunction, interferences, which is our topic for today, and defects in processes. And then the last error bucket are the post-analytical errors, and these are responsible for another fairly large percentage of lab errors. Reporting mistakes, misinterpretation of test results, or prolonged turnaround times are some common examples. Today, I'm focusing on that middle bucket, right? So errors that are usually attributed to the analytical testing phase, specifically interferences in patient samples that can lead to erroneous test results. So the Clinical Laboratory and Standards Institute, CLSI, defines interference as a cause of clinically significant bias in the measured analyte concentration due to the effect of another component or property of the sample. Now, exactly how much bias can be tolerated before the test result is unsuitable really depends upon the medical use of the test of that analyte, and that's up to the laboratory director to determine. That said, I know many laboratories simply use a 10% variation as a rule of thumb. There are certainly no shortages of possible interfering substances that can be present in blood and other biological fluid samples. Interfering substances can usually be placed into one of two buckets. Endogenous interferences, those that are shown here, are native to the sample itself. These would be things like hemolysis, icterus, and lipemia, and as well as others. And there are exogenous interferences, those that can be present due to therapeutic interventions, preservatives in the sample, dietary supplements, contamination, etc. Now, I don't have time in this webinar to delve into all possible interfering substances. There are just too many, but I do want to spend some time on some commonly encountered ones. So a very commonly encountered interference, as we all know, is hemolysis. Hemolysis occurs in blood samples when red cells are lysed and release their intracellular contents into the serum or plasma. Hemolysis is the most common source of pre-analytical error and a major reason why samples are rejected for analysis. Hemolysis is infrequently due to in vivo causes. It is far more likely to occur in vitro, either during the collection of the blood sample or transporting it to the laboratory or when being processed. There are several ways in which hemolysis contributes to analytical interference. The intracellular compartment of red cells contains a variety of analytes that are commonly measured in serum. And when red cells lyse, they release those analytes into the serum, thereby increasing their measured concentrations. Here are a few examples of analytes that are commonly measured in serum and the concentration of those same analytes in red blood cells shown as a relative abundance. So for example, compared to concentrations in serum, lactate dehydrogenase and phosphate are really present in very high abundance in red cells, while others like potassium, AST, and folate are moderately abundant. It goes without saying that how much positive bias occurs depends upon the specific analyte and the amount of hemolysis that's present. Another way hemolysis can interfere with chemistry tests is via spectral interference. Hemolyzed samples appear red in color because the heme group of hemoglobin absorbs light very strongly at wavelengths less than 620 nanometers, leaving the longer red wavelengths of light to be transmitted. And as you can see here in this hemoglobin absorbance spectra, interference of hemolysis occurs due to the ability of hemoglobin to absorb light at peak concentrations like 415, 540, and 570 nanometers. Those are the dashed vertical lines. This characteristic of hemoglobin causes optical interference that can lead to either falsely increased or decreased concentrations of an analyte, depending upon how it's measured spectrophotometrically. Again, the direction and degree of the interference really does largely depend upon the analyte being measured and the analytical method that's measuring it. And lastly, hemolysis can cause measurement errors due to chemical interference. For example, various red blood cell components may affect the measurement procedure by directly or indirectly competing for molecules in the reagents. It can inhibit indicator reactions or modify the analyte by complexation, proteolysis, or precipitation. And don't forget, too, that hemoglobin itself can interfere with various assays through its pseudoperoxidase activity. And while we don't often think of hemolysis interfering with immunoassays, we really should. Hemolysis can be a source of immunoassay interference by modifying the reaction analytes, those being the antigens and antibodies in an immunoassay, by proteolytic action of red blood cell enzymes. Icterus occurs when the concentration of serum bilirubin is about 5 mg per deciliter or greater, and that begins to turn the color of serum to yellow, green, or even brown, depending upon the bilirubin concentration. Icteric samples are usually encountered when collected from patients with liver disease because the liver plays an important role in the conjugation and excretion of bilirubin. That's the end product of heme metabolism. And it's important to remember, too, that bilirubin is present in both unconjugated and conjugated forms. And these different forms of bilirubin may exert different interferent effects in different reagent systems. Like hemoglobin, bilirubin can also cause spectral interference. Bilirubin absorbs light very strongly between 400 and 475 nanometers. And when present, these high background absorbances can lead to absorbance readings in excess of the linearity of spectrophotometric methods. Bilirubin can also cause chemical interference by acting as a reducing substance because it is very easily oxidized to biliverdin. And any assays that use an oxidase or a peroxidase-based reaction to produce a measurable product may yield lower results because bilirubin reacts with the peroxide formed in the test system. Lipemia is caused by the presence of high concentrations of large lipoproteins, such as chylomicrons and very low-density lipoproteins, both of which can cause samples to appear turbid because of the amount of light that they can scatter. So lipemic samples are usually observed when blood is collected postprandially or from patients undergoing parenteral nutrition infusions that contain lipid. Some lipid disorders themselves can also lead to high concentrations of chylomicrons and or VLDL particles. Now, one way that lipemia causes interference is by absorbing light, causing a decrease in the intensity of light passing through the sample. The ability of lipoprotein particles to absorb light is manifested largely in the range of 300 to 700 nanometers, and absorbance is greatest at lower wavelengths. And that's why many enzymatic methods in which the end product is measured at 340 nanometers are very strongly affected by the presence of lipemia. Lipemic samples can also scatter light. That's what makes the sample appear turbid. And the scattering of that light occurs in all directions, and its intensity depends upon the number and the size of the lipoprotein particles that are present, as well as the wavelength of light being used for measurement. And for that reason, light scattering of lipoprotein particles causes significant interference with both turbidimetric and nephelometric methods. Now, lipemia can also cause interference in some tests due to what's known as the volume depletion effect. The total volume of serum is comprised mostly of water, but about 7% of that total serum volume are actually solids, like lipids and proteins. And those solids are suspended, not dissolved, in the water phase. In contrast, most analytes, such as the electrolytes, are dissolved in the water phase of serum. So when a fixed volume of serum is pipetted for dilution, say 10 microliters, only 93% or 9.3 microliters of that volume is water. So if the actual concentration of an analyte dissolved in the water, like sodium, is 150 millimolar, its actual measured concentration is 140 millimolar, because the concentration is expressed as the total serum volume, not just the water volume. Now, this negative error has been recognized for decades, and reference intervals take this negative error into account. And it's not really a problem until the volume of plasma water is decreased due to an increase of serum solids, such as may be the case with lipemic samples. So in a hyperlipidemic sample, shown here on the right, I'm showing only 75% of the serum volume is water. So now a 10 microliter aliquot of serum contains 7.5 microliters of water. And so the sodium concentration in the water phase is still 150 millimolar, but it's now measured as 113 millimolar. And that's a condition that we refer to as pseudo-hyponatremia. Now remember that this type of error only occurs when the serum sample has to be diluted, as is the case with many automated methods for measuring electrolytes, such as sodium. Methods that don't require dilution of the serum, such as direct ISE measurements, don't show this type of interference. Another possible source of interference that's unique to lipids is caused by partitioning. So prior to centrifugation of a blood sample, lipoproteins are homogeneously distributed throughout the sample. But during centrifugation of a lipemic sample, the lipoproteins are not homogeneously distributed in the serum due to the creation of a lipid gradient. Water-soluble analytes tend to be more concentrated in the lower layer of serum, whereas lipids and lipid-soluble analytes are more concentrated at the top, lipid-rich layer. Now that's especially important in automated chemistry analyzers that have fixed path lengths for the sample probe. Test results may actually differ for those analytes that are not evenly distributed between the lipid and water portion of the sample, depending upon where the sample probe aspirates. And lastly, lipemia can affect immunoassays by masking the binding sites of antigens and antibodies and thus physically interfering with the antigen-antibody binding. Also, an excess of lipoproteins can interfere in electrophoretic and chromatographic methods by causing abnormal peaks. So how do we deal with interference from hemolysis, icterus, and lipemia? Well, the best way to mitigate interferences from those things are to prevent them from happening in the first place. Hemolysis most often occurs in vitro, so strategies to reduce hemolysis during sample collection and transport can be investigated and put into practice. Ultracentrifugation can be used to remove or reduce lipemia in affected samples when necessary, but keep in mind that that would not be acceptable for measurement of analytes that are normally distributed in the lipid layer, or for lipid measurements themselves, as they would be falsely decreased in those situations. Now, it isn't possible to remove bilirubin from a sample, so interference from icterus just has to be managed. Most automated chemistry analyzers have the ability to estimate the abundance of hemolysis, icterus, and lipemia in all samples, and these HIL indices can be used to evaluate the acceptability of a sample for analysis. Labs that utilize that mitigation technique, though, have to establish, or they should establish, thresholds for the various interferences that would potentially compromise the test result. And of course, recollecting the sample may also be required. So moving on to a different type of interference, monoclonal antibodies. So monoclonal antibodies are a rather common source of interference, and several types of interferences have been described in the literature. Importantly, these interferences are dependent on both the analytical method and the concentration of the monoclonal antibody, with the likelihood of interference increasing with the concentration of the antibody. This type of interference includes both endogenous monoclonals as well as those that are being used now in immunotherapies. Monoclonal antibodies most commonly cause interference because they can precipitate in chemical reactions. So here we see interference in a turbidimetric assay for gentamicin. So the top panel represents a typical normal reaction with turbidity increasing over time once the reagent is added and immune complexes form as a function of the drug concentration. And you can see that the reaction curve shows an expected positive slope. Now the bottom panel shows the same reaction, but now in the presence of an endogenous IgM monoclonal protein that precipitates out of solution upon the addition of the assay reagents. And that precipitation increases the turbidity of the sample and produces an abnormal reaction curve. Many tests can show interference due to the presence of monoclonal antibodies, but the cause is usually the same. That would be precipitation. Here we see absorbance curves for samples without monoclonal antibodies, that's shown in the dashed lines, and with monoclonal antibodies, shown in the solid lines. And it should be clear, just upon inspection, that these curves are very different from each other, and as such, the test results would be inaccurate in the presence of the monoclonal protein. While endogenous monoclonal antibody interference has been appreciated for many years, interference from therapeutic monoclonals, or immunotherapies, are really a more recent development. And this type of interference is most commonly seen in serum electrophoresis tests. As examples, elotuzumab and daratumumab are two therapeutic monoclonal antibodies that are used to treat patients with multiple myeloma. Now, both of these drugs, most of these immunotherapies, can cause abnormal peaks in the gamma region of the serum protein electrophoresis. And in the laboratory, the challenge is knowing if these peaks are due to endogenous antibody or a therapeutic antibody. And knowing that is important because monitoring of disease progression in patients with multiple myeloma includes routine serum protein electrophoresis and immunofixation for the detection of disease-related monoclonal antibodies. So false positive or misleading results caused by immunotherapies are a real concern. Strategies to mitigate interference from monoclonal antibodies include sample dilution, because it would dilute out the concentration of the monoclonal, thereby decreasing its effect, or the need to remove the offending antibody by either precipitation, ultracentrifugation, or adsorption. Now, another type of antibody can also interfere in immunoassays specifically. So interfering antibodies, as I'm going to call them, are also referred to as heterophile antibodies, and these are endogenously produced immunoglobulins that have specificity against the reagent antibodies used in immunoassays. Now, because many reagent antibodies are derived from mice, the interfering antibody is oftentimes a human anti-mouse antibody. And when these antibodies, these interfering antibodies, are both present and reactive against the reagent antibodies, they can cause false positive or false negative immunoassay test results. Shown here is the mechanism by which these antibodies can produce a false positive result. Shown on the right, the interfering antibody can cross-link both the capture and the labeled antibodies in a sandwich immunoassay, thereby giving the appearance that the antigen is present even when it is not. Now, interfering antibodies can also cause negative interference and produce falsely decreased results, although this type of scenario is less common. The negative interference is caused by the interfering antibody binding to only one of the two reagent antibodies, thereby preventing the reaction with the antigen. There are a few ways that we can investigate if samples are affected by interfering antibodies. The use of commercially available blocking agents can be used to remove the interfering antibody, and manufacturers often, but do not always, include such blocking agents in the immunoassay reagents themselves. Another method is to do dilution studies on the sample in question and determine the recovery of the antigen from those diluted samples. Because interfering antibodies are reactive against the assay reagents and not the measured antigen, diluted samples that contain these interfering antibodies often produce results that fail to recover the antigen as expected. Also, you could perform the test using a different immunoassay that employs antibodies produced from a different animal species. However, keep in mind that some interfering antibodies can show broad specificity and can cross-react with antibodies from multiple animal species. However, none of these methods are foolproof, and it's often helpful to perform more than one of them when investigating suspicious samples. So another interferent is the high-dose hook effect, which I imagine many folks are familiar with. And that occurs when there's a very high concentration of an antigen. As an example, in a sandwich immunoassay, the measured signal is proportional to the antigen concentration because the antigen is sandwiched between the two reagent antibodies. If the antigen concentration is extremely elevated, shown on the right, then antigen molecules saturate both the capture and the labeled antibodies, which prevents formation of the sandwich, and that results in a signal that is lower than what it should be, thereby producing a falsely decreased result. When the high-dose hook effect is suspected, diluting the sample is the way to investigate. The goal is to dilute the antigen concentration into the analytical measuring range of the assay in order to produce a reliable result. So drugs and their metabolites are also common interference in many different types of lab tests. And they can cause interference indirectly, like the first two examples in the table, or they can cause interference directly, such as the last two examples in the table. Now, because of their sheer abundance, there are likely thousands of possible interferences, and many of them are unknown simply because they haven't either been discovered or studied. And the same is true for dietary supplements, the use of which has risen dramatically over the years. And like drugs, the effects of these may be unknown, but there are some that are well known to cause interference. And the vitamin supplement getting the most attention today, it's no secret to anyone, is vitamin B7 or biotin. So biotin is a water-soluble B vitamin that functions as a coenzyme for multiple carboxylase enzymes, and it's readily available from food sources, so biotin deficiencies are quite rare. There is no recommended daily allowance for biotin because of a lack of evidence to establish one, and instead, the National Academy of Medicine's Food and Nutrition Board established that an adequate intake of biotin is 5 to 35 micrograms per day. So because biotin deficiency causes skin rashes, hair loss, and brittle nails, the supplement industry has promoted biotin supplementation as essential for hair, skin, and nail health, but there's really scant evidence to support such claims. Despite that, biotin consumption in amounts that are thousands of times greater than needed have risen dramatically. Now, clinically, very high doses of biotin are being used in clinical trials to treat progressive multiple sclerosis. So there's really three buckets here. Adequate intake, which you get from a normal diet, about 5 to 35 micrograms per day. In over-the-counter supplements being advocated for hair and nail growth, we're talking concentrations of biotin in these capsules that are thousands of times greater than the adequate intake amounts. And then extremely high concentrations, 300 mg per day, in clinical trials that are being used to investigate as a treatment for progressive multiple sclerosis. So based on recently published pharmacokinetic study, healthy subjects taking 5, 10, or 20 mg of biotin daily, that's shown in the green, blue, and red lines, 5, 10, and 20 mg per day. They demonstrated median peak serum biotin concentrations 1 hour after dosing of 41, 91, and 184 nanograms per mil, respectively. So that's shown, I wish I could point, but it's, I think I can, hold on. No, I can't. So you're going to have to, it's in the x-axis, it's the points that are shown there at day 3, D3.T3, day 3 times 3. So essentially we're showing that they took high doses of biotin, and then 8 hours later concentrations had fallen down to, peak concentrations were achieved 1 hour later, and then 8 hours later concentrations had fallen quite low, or less than 30 nanograms per mil. However, you can also appreciate that there was accumulation of biotin in the serum over 5 consecutive days of dosing. So you can see in the next peak, which followed the next dose, the concentrations did fall rapidly by 8 hours, but they were a little bit higher than they were following the first dose. In this particular study, the reported half-life of biotin was 15 hours. So why is all of this important? It's because biotin is widely used with streptavidin as a reagent in many immunoassays, and exogenous biotin can cause interference. So streptavidin is a tetrameric protein with a very high affinity for binding biotin, and the binding of biotin to streptavidin is one of the strongest non-covalent interactions known in nature. Some immunoassays utilize streptavidin-coated microparticles to capture biotinylated antibody or antigen, and these types of assays can be vulnerable to biotin interference. So let's take a look at how biotin can interfere in immunoassays that utilize biotin in the reagent system. So in a non-competitive immunoassay shown here, antigen in the patient sample is incubated with a biotinylated capture antibody and a different labeled antibody. These complexes are subsequently captured by a streptavidin-coated microparticle, and when the signal intensity is measured, they would be proportional to the analyte concentration, the antigen concentration. However, if the patient sample contains excess biotin, then these excess biotin molecules will bind to the streptavidin-coated microparticles, thereby reducing the ability of the antigen-antibody complexes to bind. That produces a lower signal and gives the appearance of low results that are falsely decreased. In contrast, in a competitive immunoassay, labeled reagent analyte competes with analyte in the patient sample for binding to a biotinylated antibody. And then these complexes are also captured on the streptavidin-coated microparticle, but now the signal intensity, because it's a competitive assay, is inversely proportional to the analyte concentration. So if the patient sample contains excess biotin that binds the streptavidin-coated microparticle, the signal will be reduced, and that will make it appear as though the analyte concentration is elevated. So it's important to note that interference from biotin is difficult to predict, and it depends on several variables. These variables include the concentration of biotin in the sample and the interference threshold of the assay. Not all assays that use biotin as a reagent are affected, and among those that do, different assays show different sensitivities to interference. That said, higher biotin concentrations tend to produce greater amounts of bias. Now, most major immunoassay reagent platforms are susceptible to biotin interference, the exception being those that do not use biotin streptavidin in their immunoassay design. There are several published case reports about biotin interference. Here's one. So in this case, it was a 63-year-old female was referred to an endocrinologist because she had very elevated free T4, which was measured by a competitive immunoassay, and a very low TSH concentration, and that was done by a sandwich non-competitive immunoassay. And so she had biochemical evidence of hyperthyroidism, but she had no symptoms of hyperthyroidism, although she did have progressive multiple sclerosis for which she had been prescribed high-dose biotin therapy. So that was obviously suspected as the cause of the interference. A new sample was collected 16 hours after her last dose of biotin, and you can see that the results are significantly changed, right? So now she still has elevated free T4, but her TSH is in the reference interval. And that was 16 hours after her last dose. If another sample had been collected, I'm willing to bet that free T4 would have been in the reference interval. In another case, a 48-year-old female with hirsutism and subclinical hyperthyroidism had multiple abnormal endocrine tests, here shown in the table. So notably, cortisol and testosterone, which were both measured by competitive immunoassay, were quite elevated, whereas FSH, LH, and prolactin, measured by a non-competitive sandwich immunoassay, were all decreased. Now, the patient indicated that she was taking over-the-counter biotin supplements at 5 milligrams per day, and she was told to discontinue using them so that the biotin could clear, and then the test would be repeated. So the tests were repeated 3.5 weeks later, but they continued to produce the same abnormal results. So the patient underwent actually several interventions to investigate the cause. So she had an MRI to rule out a pituitary adenoma, but there was none, a CT to rule out an adrenal tumor, but there was none. She had a pelvic ultrasound to evaluate an ovarian tumor, and nothing was found. So she was scheduled to have her uterus and ovaries removed surgically because a small testosterone-secreting tumor couldn't be ruled out. Testosterone was then measured by a tandem mass spec method, which is not susceptible to biotin interference, and the results of the testosterone were normal. And upon further questioning, the patient indicated that she had not stopped using the biotin supplement, but given the choice of that or surgery, she opted to stop taking the biotin. And 2 weeks later, tests were repeated, and testosterone was normal by immunoassay and by mass spec, and her thyroid tests were now within reference limits. So it's cases like these, and there are many others that have been published, it's cases like these, as well as a reported patient death from a false negative troponin test that was attributed to biotin interference, that prompted the FDA to issue a safety alert last November. And in it, they recommended increased awareness about biotin use in all affected communities, those communities being patients, care providers, and laboratorians. They also called in their safety alert, they called for increased education and communication about the possible risks of high-dose biotin supplementation on lab tests prior to sample collection. So what do we do about it? Well, there are several ways to mitigate biotin interference. Preventing the problem is the best strategy, and so raising awareness of the potential for biotin interference is important. That said, educating patients and providers, as we all know, is not a very easy thing to do. And patients often don't even realize they're taking biotin supplements because some products are just simply labeled as hair or nail vitamins. And of course, notices that we do push out to providers and patients often go unnoticed and unread. Another strategy would be to append comments to test results alerting to possible interference, but I really think that would be overkill for many tests and would likely lead to alert fatigue and eventually just be ignored. Now, if patients are known to be taking biotin, they should be advised to discontinue its use prior to sample collection. The half-life of biotin in the blood is brief, and studies have reported half-lives that range between 2 to 15 hours. Once alerted to the fact that a sample could contain excess biotin, lab personnel can take steps to prevent interference. One strategy would be to use an alternate assay that doesn't use biotin as a reagent, but that can be very impractical, and an assay may not be readily available in your lab or locally. Another strategy is to remove the excess biotin from the sample using streptavidin-coated microparticles to absorb out the exogenous biotin. However, that option would be considered an off-label use of a test, and validation of the process and appropriate QC would need to be performed by the laboratory. And manufacturers can help by redesigning their assays, such as pre-complexing the biotin and streptavidin in the reagents, or by using alternate linkage methods. However, such an assay redesign would require FDA review, which is a lengthy process with a long lead time, not to mention costly. So interest in biotin seems to have reached a plateau in the United States. I use Google Trends to analyze the popularity of the word biotin as a search query in Google, and the results show that the interest in biotin began increasing in 2008 and peaked in 2014, but it has leveled off since then. Still, it appears to remain a popular search query, suggesting that there is continued use or continued interest in biotin as a supplement. Now, concern about biotin interference has garnered a lot of attention lately, and perhaps even more so since the FDA issued its safety alert. And while it is an important issue, it's also important to remember that it's just one of many interferences that we face every day in our laboratories. And others share that same sentiment. Here, Dr. Tran at UC Davis reminds us that biotin is just one of many interferences that we encounter daily. And Dr. Master from the University of Pennsylvania points out that biotin is neither the first nor the last of interferences that will be important. So I hope I've shown you that there are many endogenous and exogenous compounds that can interfere with lab tests, and that biotin in particular has gained increased attention due to increased utilization of the vitamin and the impact that it can have on immunoassay test results. But regardless of the interference, it's critical for us, for laboratory professionals, to understand and explain the various sources and mechanisms of interference, because we play a critical role in managing and mitigating them. That's all I have for you. Thank you very much for joining me today. I'd be happy to address any questions that you might have.
Thank you, Dr. Grenache, for sharing your presentation with us. I would like to remind everyone that you can ask a question via the Q&A box at the bottom right-hand corner of your screen. We have had a few questions lined up already, so Dr. Grenache, I will ask the first question that we have here for you. How can labs detect when the hook effect is occurring?
So it's difficult for labs in many cases to detect the hook effect when it's occurring because the results that are produced aren't particularly notable. So it is difficult for labs to independently identify when the hook effect is occurring. We really do rely on our clinical colleagues to alert us to the fact that something doesn't make sense. And so that's a common theme that I always tell the clinicians that I interface with. I'm like, if something doesn't seem right, if a lab test seems to not fit the clinical picture, you should definitely get a consult from the laboratory. And once we're alerted, then we can take steps to investigate. And the same would be true for the interfering antibodies, like the heterophile antibodies that I described. It's very difficult for us to identify when that problem is occurring. We do rely on our clinical colleagues to alert us. That said, there are some immunoassays, particularly thinking of some nephelometric tests, that are susceptible to the hook effect. There are some ways in which software can monitor the rate of the reaction to indicate that the hook effect is occurring, and then there are steps to take the instrument off. The software usually instructs the instrument to make a dilution and rerun the sample. But for most immunoassays, it's not easy for us to identify independently.
Thank you. Here's another question, Dr. Grenache. How do lab personnel even know when to investigate samples for possible interfering antibodies?
Yeah, it's kind of the same answer that I had for the last question. Again, we don't necessarily, there's no way that we can tell, that anyone can tell by looking at the sample that there's an interfering antibody. And so if results don't fit the clinical picture, then let the lab know and we can investigate. So by example, last month I think I got a call from an endocrinologist who was questioning the results of a thyroglobulin test result that we had reported. It was high, it was elevated. It came from a patient who had had a thyroidectomy. She was having thyroglobulin tests to monitor recurrence of thyroid cancer, and suddenly the results were elevated and they hadn't been in the past. So there was concern, of course, about possible recurrence. So I said, well, let me investigate, and one of the first things I did was treat the sample with a blocking agent, and the results were considerably lower, which supported the idea that there was an interfering antibody. We did some other subsequent investigations, and all findings pointed to the fact that there was an interfering antibody. But we would never have known that that was the case unless the provider had contacted us.
Wonderful. Thank you, Dr. Grenache. Here's the next question. How often are samples containing excess biotin encountered in the laboratory?
Excellent question. The million-dollar question. It's really difficult to know how often samples that contain excess biotin are coming through our laboratories. It's not been well studied, probably because of the recent trend in using biotin. But there was a recent report out of Mayo Medical Laboratories, I think the paper's in press, and I stumbled across it a few days ago, so I'm glad you asked that question. So this report out of Mayo found that almost 8% of outpatients who they surveyed indicated they were taking biotin supplements. So they surveyed outpatients and said, are you taking biotin? And 8% indicated that they were. But they also took a random sampling of samples that came to the laboratory through the emergency department, and they tested them for biotin using a lab-developed mass spec test for biotin. And they discovered that 7% of those emergency room samples contained biotin at a concentration that was at or above 10 micrograms per liter, which is a concentration of biotin that can interfere in some immunoassays that use biotin in the reagents. So that's actually a startling high number, 7% of samples that contain biotin. But you have to appreciate, too, that that was done at one location up in Minnesota. Does that reflect, I would imagine there would be regional differences in biotin use across the United States and in other countries as well. Great question. Best answer is uncertain, but a study that was recently done in Minnesota showed that about 8% of outpatients claim to be taking biotin, 7% of samples from the ED randomly selected contained biotin at concentrations that could interfere.
Thank you. Here's the next question, Dr. Grenache. What are the known interferences for urine assay?
What are the known interferences for urine assays?
That's right.
Well, gosh, there's lots. The first thing I think about urine toxicology tests. We know there are false positive and false negative results due to either cross-reacting compounds or the inability of immunoassays that are used in urine drug of abuse testing to detect parent or metabolite compounds. Other things that can be present in the urine, lots of things end up in the urine that we consume, both drugs and supplements. Those can certainly likely lead to interference. So it's hard to point to just one. People people who have hematuria or blood in the urine, the hemoglobin can interfere for the same reasons I just described. There can be bilirubin in the urine. So there's lots of I think the take-home message is there are a lot of interferences, both in blood and urine, and we really, I think, only know or appreciate a handful of them.
Thank you. Here's the next question, Dr. Grenache. Is it a standard rule that sandwich assays will be suppressed by biotin and competitors will be falsely elevated?
I think so. Everything that I've ever read about biotin and interference in immunoassays has consistently shown that sandwich immunoassays are falsely reduced, and competitive immunoassays give falsely increased results. If someone has encountered a different scenario, I'd certainly like to know.
Thank you, Dr. Grenache. We have a few more questions. The next question is there a good way to convert HIL indices? I'm sorry, I need to see the question. Sorry. Is there a good way to convert HIL indices to concentration of hemoglobin, bilirubin, or lipids?
I think you could establish that relationship. I'm not quite sure why you would necessarily want to. Certainly manufacturers don't advocate for doing that, for turning those indices into concentrations. Maybe you could for hemoglobin, but for lipemia and icterus, probably not so much. I'm not quite sure what the need would be. But you could probably establish it if you define the relationship using known standards. But that would be hard to do for something like lipemia, because lipemia is, as I described, occurs when there are abundant lipoprotein particles that are large enough to scatter light. And so lipemia isn't a molecule; it's a thing.
Thank you. Here's the next question. Should we measure biotin at least for immunoassay affected, like we do hemolysis, icterus, and lipemia?
Well, if we could, that might be a strategy to mitigate the problem. Right now, there are no, to my knowledge, there are no commercially available assays for measuring biotin that are available. Most assays that I'm familiar with are tandem mass spec methods that have been developed by laboratories. So, there are methods to measure biotin, but then you have to think about how you incorporate that type of measurement into your workflow. Right now we do HIL measurements on our samples because that's a photometric test that can happen within an automated chemistry analyzer, but there's no photometric method like that can be used to assess how much biotin is in a sample. So unless you had an easy and very inexpensive way to assess biotin in every sample, I don't see that as viable.
Thank you, Dr. Grenache. Here's another question. How do we determine icterus index if there is one for direct and one for indirect, and my machine only accepts one number?
Could you read that again?
Sure. How to determine the icterus index if there is one for direct and one for indirect, and my machine only accepts one number? We can get back to this question later, Dr. Grenache. We can email the participant who has asked this question. Okay, then let's go on to the next question. Is that all? Okay, let's just give it maybe a few seconds before I obtain the next question. Here's another question, Dr. Grenache. Do you think that 10% bias is too little for interference?
I think it's, personally, I think that the amount of bias that should be tolerated is a function of the medical, the allowable error, right? So I understand why many laboratories will just default to 10% because it's an easy number, you can apply it across everything, but it's probably more appropriate to select allowable error or allowable bias as a function of the medical need, how the test is used clinically. So some could tolerate more, some could tolerate less. But it's more work. It's much more laborious to establish those types of thresholds for every different analyte.
Thank you, Dr. Grenache. So we have time for one more question, and this is the last question. Has anybody considered testing a sample for biotin after receiving abnormal results from biotin-sensitive assays?
Has anybody considered testing a sample for biotin after receiving abnormal results from biotin-sensitive assays? I don't understand the question.
That's okay. We can get back to the individual who has asked that question. We can follow up with the AACC education inbox, and we can follow up with them later. So that's all the time we have for the Q&A. However, if you have submitted a question which have not been answered, we will get back to you via email. So this concludes our Q&A, and I would like to once again thank you, Dr. Grenache, for providing this excellent presentation. And thank you all in the audience for listening to this ortho-clinical diagnostic webinar. When you close out of this webinar, you will be taken to the Axon website, where on completion of the evaluation form, you can gain your Axon continuing education credit. Later today, you will receive a message from AACC with the playback link to today's session. If you have any questions following this program, please call our customer service line at 800-892-1400. Thank you, and have a great rest of the day.